Today, we'll discuss how to recognize and manage strokes in the pre-hospital setting. As EMTs, you're often the first medical contact for these patients, and your early recognition and response can directly affect outcomes. By the end of this lesson, you should be able to define what a stroke is and recall the different types. You should be able to recognize the signs and symptoms of a stroke and explain why the person's last known well time is so important. You'll also be able to assess, manage, and transport a stroke patient per our protocol. A stroke occurs when blood flow to an area of the brain is interrupted or reduced. Without oxygen, brain tissue begins to die within minutes. There are two primary types of stroke, ischemic and hemorrhagic. While both cause brain injury due to interrupted oxygen flow, they're very different in cause, presentation, and treatment urgency. We cannot determine the type in the field, but recognizing that a stroke is a stroke and that it's time sensitive and getting care moving is very important. Let's start with ischemic strokes. These account for roughly 85% of all strokes. They occur when a blood clot or an embolus blocks blood flow to part of the brain, preventing oxygen from reaching tissue downstream. There are different causes, such as a thrombus that forms in the brain's own arteries, often from plaque buildup, or you have an embolus that travels from elsewhere, commonly from the heart in AFib. Think of a stroke like a blocked pipe. Everything downstream loses flow. In the brain, that means brain tissue dies quickly. Some common findings to look for are sudden weakness or numbness, usually one-sided, facial droop or slurred speech, arm drift, or loss of coordination. You can also have confusion or vision changes. Now, these patients often remain conscious but have focal neurological deficits. The onset could be sudden and dramatic. A hemorrhagic stroke, these are less common but much more severe. Instead of a blockage, there's a ruptured blood vessel leaking into or around the brain. Some common causes are chronic hypertension, an aneurysm that ruptures, malformation of the brain, or trauma and anticoagulant use. The bleeding increases pressure inside the skull, compressing brain tissue and reducing blood flow further. This results in both oxygen loss and physical damage from swelling. Some typical signs you might see are sudden severe headache, which the patient describes as the worst headache of their life. You can also have nausea and vomiting, altered mental status or loss of consciousness, unequal pupils or vision changes, and very high blood pressure. Here's a comparison of the two types. Some big takeaways are that even though they both present the same with regards to our BFAST assessment, which we will discuss soon, they have differences, but in the end, we treat both the same in the pre-hospital setting, and definitive care is needed to correct both. Ischemic strokes may be reversible if recognized early. Some patients qualify for clot-busting medications such as TPA or thrombectomy. Hemorrhagic strokes require a completely different approach. Giving TPA would make the bleeding worse. That's why CT imaging is always done before treatment begins. Signs and symptoms can vary depending on the part of the brain affected, but the classic findings include facial droop, arm drift or weakness, speech difficulty, sudden confusion, vision changes or severe headache, and loss of balance or coordination. How we assess these is by using BFAST, which is out of our protocol. Balance. Is the person experiencing any sudden loss of balance or coordination? Eyes. Is the person having a sudden change in vision or trouble seeing or abnormal pupils? And face. Does one side of the face droop? Arms. Does one arm drift when you have them close their eyes and lift their arms? And speech. Is their speech slurred or strange? You can have them repeat a sentence, or you can tell from their answers to your questioning. And then time. What time did the symptoms begin? When was the patient last known well? Now we'll discuss the importance of the last known well time. Stroke care is all about time. One of the most critical pieces of information we gather is the patient's last known well time. That's the last time the patient was seen without symptoms. This determines whether the patient is eligible for thrombolytic therapy like TPA or mechanical thrombectomy. For ischemic strokes, the ones caused by a clot, there's a limited window in which clot-busting medications like TPA or mechanical thrombectomy can be given safely. If that window is missed, the risks of treatment, especially bleeding, become greater than the potential benefits. That means the clock doesn't start when you arrive. It starts when the patient was last seen normal. That's why accurate history is vital. Hospitals use the last known well time to determine whether a patient goes to a primary stroke center or a comprehensive stroke center with interventional capabilities. If you can provide that time accurately, the receiving facility can activate the stroke team and prepare for imaging and intervention before your arrival. It's not always easy to find the exact time, especially when the patient lives alone. Family members found them hours later. The onset was during sleep, which we call a wake-up stroke. In these cases, document the last known well time as the last time the patient was observed at baseline, not when symptoms were discovered. An example is, if a patient went to bed at 10 p.m. and was found with slurred speech at 6 a.m., the last known well time is 10 p.m., even though symptoms were noticed at 6 a.m. As part of your assessment, it is important to make sure that you are looking for treatable medical conditions that look like a stroke, such as hypoglycemia, hyperglycemia, hypothermia, hypoxia, hypotension, encephalopathy, infection, seizure, and/or hyperthermia. Not all neurological deficits are caused by a stroke. These are important to look for because they can be treated. A stroke is a time-sensitive emergency. Don't linger on scene, get going. Use validated tools out of our protocol for assessment, such as BFAST. Determine the last known well time early. Maintain oxygenation and monitor blood glucose. We want our patients to be titrated to 94% SpO2. Do not over-oxygenate. Blood glucose should be evaluated to rule out hypoglycemia, which can mimic a stroke. Provide early hospital notification to get the stroke team rolling as soon as possible. Always transport to an appropriate stroke center when available. Figure out, does the patient need to go to Mimo or Penrose, Maine for comprehensive care? To close, let's review a few quick questions. Pull your protocols out and review these questions as a group. What are the two primary types of strokes? Why is the last known well time so critical? Which stroke assessment tool do we use? And when should you activate a stroke alert? You can find the answer to those all in our protocols. So good luck and have fun.